Okay, this is a really cool case of a rectus femoris muscle tear. This was a 39-year-old male soccer player who presented with anterior thigh pain right around the anterior inferior iliac spine. This started during a soccer match earlier in the day, and the patient states he felt a snapping sensation while he was playing soccer. On physical exam, his vital signs are fine. He is noted to have trouble, or actually, he really can't even walk on the affected leg. There's some swelling on inspection, exquisite tenderness with some fluctuance. Maybe there's a little hematoma there. And he has pain with hip flexion, and it feels a little bit weak compared to the unaffected limb. And there's a palpable gap near the anterior inferior iliac spine. So here's his imaging from the emergency department here on the left. And this is an ultrasound. What you can see here is edema and swelling around the rectus femoris muscle belly here. And then the same thing in the long axis here. You see this edema and swelling. There's no comparison here, but this is essentially what muscle injury looks like on ultrasound. He was able to get a fairly expedited MRI 6 days after injury. And you can see here the right rectus femoris really on these T2 weighted images shows edema around the tendon, and you can see some retraction here off the anterior inferior iliac spine as well. So let's talk about rectus femoris muscle injuries. These are the number one muscle injury of all four quadriceps muscles, sustained during eccentric contractions, right? So that's a contracting muscle while it's lengthening. And the rectus femoris is a biarticular muscle within the quadriceps. And that biarticular means it crosses two joints and makes it particularly susceptible to injury. It helps with knee extension, hip flexion, and then during gait and standing, it helps with pelvic stabilization. Sports that involve sprinting and kicking are the ones that are most commonly encountered for rectus femoris injuries, especially kicking. And then you think about sports like soccer, American football, rugby. The differential diagnosis is pretty broad, includes hamstrings and adductor injuries, femoral acetabular impingement, acetabular tears, radicular disease from the back, injury to the ligamentum teres, hip OA, AVN, osteochondral defect of the hip and loose bodies, hip microinstability, pelvic stress fractures, osteitis pubis, sports hernia, avulsion fractures of the pelvis, which our guy does not have, but he has an injury at the AIIS, snapping hip syndrome, and iliopsoas tendinopathy, and that's not even a complete differential. On physical exam, on history, you typically characterize a sudden tearing sensation and quitting or discontinuing the sport, and then acute injury in a more insidious one. It's gradually worsening pain during running and kicking. Acute injuries more commonly are in the thigh, as opposed to subacute or groin pain. On exam, the pain is typically characterized by active or passive stretching of the quadriceps muscle group in the rectus femoris, palpation wherever the injury occurred, and then resisted knee extension and hip flexion. Okay, and then in this image right here, you can see this is the thigh of an athlete with a rectus femoris injury. You can actually see the bulge here where there's a defect, and then there's some swelling here. So this is more of a distal injury, distal kind of anterolateral, not the exact same injury as our patient. Diagnosis, so x-rays are a screening tool, typically normal. Ultrasound is useful. You can ultrasound the rectus femoris. You can compare it to the unaffected limb. Acutely, you're going to find fluid collection, maybe some degree of tendon disruption. In more chronic cases, you'll see tendon thickening, tendon remodeling. You might see calcifications or scar tissue. MRI, probably the imaging modality of choice if you really want to characterize the extent of the lesion. You're going to find signal around the muscle discontinuity, and then you can really kind of characterize the severity of the injury. On the right side of the screen here, we have an anterior inferior iliac spine avulsion fracture. So here's AIIS. You can see that it's popped off of the bone here, although just to be fair, this is a skeletally immature patient. So you always want to compare it to the other side. So here's the left AIIS, very clearly different than here. And this patient, of course, has a ton of pain at this spot. So that kind of makes sense. Treatment is focused on prevention, right? Obviously, these injuries can be avoided as much as they can. You want to focus on the flexibility, strength, and core stability. The vast majority of cases are non-surgical, which includes maybe a brief period of non-weight bearing with crutches, relative rest, ice, NSAIDs, physical therapy, and some structured return to play. Surgical cases are rarely indicated, but maybe for some really significantly displaced anterior inferior iliac spine avulsion fractures. All right, let's get back to our original patient here, this 39-year-old. He was improving after his MRI. Remember, that was at day 6. About a week later, he had a platelet-rich plasma injection into the rectus femoris lesion, the area of injury, and then started formal physical therapy. He was slowly improving with a gradual relief of his symptoms. He was essentially pain-free 2 weeks after the injection. However, he still had some weakness when using the muscle group. So he continued physical therapy. At final follow-up, he had no pain. The gap on his AIIS had basically resolved compared to the original MRI, which you can see here on the right. His range of motion and strength had resolved. And then he returned to sports at 100% about 3 months post-injury. So here you can see him squatting, and you don't really see any deficits up between the right and the left. You see him firing his quad here against resistance. No deficits. He's able to do that, and that was symmetric to the other leg. And then you look at this MRI compared to the one I showed you before, and you see no fluid collection or hyperintense signal around the AIIS or the proximal rectus femoris tendon. So 3 key points about rectus femoris muscle injuries. The first is that they're most commonly injured muscle in the quadriceps group, typically occurring during eccentric loads. Diagnosis is made clinically, like you're suspicious, and then MRI and ultrasound help clarify the extent of the injury. And most patients do well with non-surgical management, and the return to play rate is very high.